Chair.
Morning. I need to make certain you're there before I start this meeting. Honourable members, very welcome to this meeting. It's a meeting of the Portfolio Committee on Health on the 28th of September 2022. It's a virtual meeting this morning. And the purpose of our meeting is to receive a status of the COVID-19 and COVID-19 vaccines from the Minister and the Department, and also to receive 3 more presentations from them on monkeypox in South Africa, health regulations update, surgical backlogs in South Africa. Ms. Majalamba, before we proceed, can I get an idea of attendance and apologies for this meeting?
Good morning and thank you, Chair. Present is Dr. Jacobs, Dr. Harvard, Mr. Siwela, Mr. Kaba, Ms. Clark, Ms. Wilson, Ms. Ishmael, Ms. Chirwa, and Mr. Van Staden. I've received an apology from Uma Muhlengwa. Thank you, Chair.
Very welcome, Minister, Deputy Minister, the whole of the department. Mr. Joe Khatla, would you be able to give us an idea of who is present at our meeting?
Good morning, Honourable Chair. Good morning, Honourable Minister, Deputy Minister, and colleagues. The Minister is on the platform, Honourable Chair, and Minister will take over. Thank you.
Thank you very much. Honourable Minister, I've already welcomed you, but welcome again to the meeting. We're looking forward to this presentation and discussions with you. So I will hand over to you now, just to introduce or to inform us who is with you. And we'll be doing your presentations this morning.
Thank you very much, Honourable Chair. Good morning to all the honourable members. I hope I'm audible.
You're very audible. Thank you.
At least my load shedding is coming quite late today, so I hope we can sustain. I do have with me the Honourable Deputy Minister, Dr. Lomo, the DG, Dr. Buthelezi. DG, can you show your face? Dr. Buthelezi is there. Yeah, there he is. Dr. Nicholas Crisp, the DDG, is also there. He will make a presentation. It'll be the first one. We have Dr. Tulare, who will also make a presentation. Dr. Tulare, are you able to confirm? She's there, yes. We also have DG will just confirm Dr. Makanya, Dr. Nonhlanhla Makanya, who will talk to the surgical backlogs. And then the support staff from the parliamentary officer, Mr. Khatla is there, Ms. Kasamba also from the parliamentary license office. So that's the team, Honourable Chair. As we did receive the agenda for the meeting, we remain guided by yourself in terms of sequence. We are ready to start with the presentation on the COVID-19 epidemiology, just a brief overview, and then also the vaccination where we are. We are ready also with all the other 3, which include the regulations, include the monkeypox, and then the surgical backlogs. So in that order, if that is the way you want it, we are ready. If that is in order, Chair, maybe just to mention also to the members, although it's not on the agenda, we will come back with more detail at the later stage. But as everybody is concerned about the impact of load shedding on the health facilities. Just to mention that we are working with all the relevant, the Minister of Public Enterprise, ESCOM, our colleagues in the provinces, and also with various municipalities, which are some of whom are electricity suppliers. We're working with them in terms of interventions to make sure that we could mitigate against the impact of load shedding on health facilities. But we will come back at the later stage, Chair, where we could make a full presentation on what steps have been taken. But in terms of today's topics, if you give us a go-ahead, Chair, I could ask Dr. Crisp to start. Over to you, Chair.
Thank you very much, Minister. I will just hang on a little while with the presentations, but I agree with the order in which you'd raised it, so we can proceed in that order, but I need to do a couple of things still pertaining to the rules of the committee, etc. I just want to also see Honorable Sheikh Imam on the platform. I can't remember his name having been raised as being present. But again, honorable members, you need to be reminded that this virtual meeting is deemed to be in the precinct of Parliament and therefore constitutes a meeting of a committee of the National Assembly for official purposes only. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and privileges that apply in a sitting of the National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said to the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons on the bar at the bottom of their screens, which has an option that allows the member to put up his or her hand to raise points of order. The Secretariat will assist in alerting the chairperson to members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order. So, honorable members, just as a reminder that you should raise your hand on the platform. This is a virtual platform, this meeting, and I would be looking out for any hands which are raised, and we will then take your point if I see your hand being raised, honorable members. With that having been said, I saw the hand of Honorable Sukkers, but I think she's lowered her hand already. You also welcome Honorable Sukkers and Honorable Gela to the meeting. I think you've just also entered the meeting. With that said, Honorable Minister, I'm handing back to you to start, have your members of the department do the presentations. We follow from there. Thank you.
Thank you very much, Honorable Chairperson. With your permission then, I will start with Dr. Crisp. I'm just going to ask him maybe not to be too detailed, just to, I know that there's an issue of time, so especially on the epidemiology and also on the detailed, just give the substance, but try to keep it as short as it is possible. We'll start with Dr. Crisp. Yes, thank you very much, Chair.
Will do. Thank you, Minister, and good morning to you, Chair, and to the honourable members. Morning again to the Minister, Deputy Minister, colleagues, and members of the media and the public. As Minister said, there are quite a lot of slides, but I'm just going to show some highlights, and the rest are available for you to look at. So what we'll do is very briefly look at a couple of slides on the COVID-19 status at the moment, and then concentrate on what's happening with vaccinations. So from the status, what this graph shows is the cumulative numbers of cases, but it also shows the current numbers of cases are very low. And we're going to see that in the second graph as well, where we're looking at provinces. These are the different case loads of the province in each province over the period since the beginning of the epidemic. And you will see the case numbers are still extremely low in all provinces. And in terms of age group, the same pattern we are seeing. We haven't seen a new upturn yet in this. In terms of what is causing the current cases and what has happened over the period, the top half of this graph shows us the numbers of sequences that are being done, and it's related to the numbers of tests. Very low number of sequences being done at the moment. And you can see by the colors, this yellow color and the orange color, it's all exclusively Omicron that is being diagnosed, sequenced at the moment. And it's BA4 and BA5 that dominate. We have not seen much by way of any other at the moment, any other variants at the moment. In terms of our vaccinations, there have been 37.6 million vaccinations done. You remember this period at the beginning was the Sisonke program, then the mass programs that ran, and now since the beginning of the year, it has tapered off, and at the moment there's very little vaccination that is taking place. We have reached 51.29% of all adults have received at least one vaccination. And what is pleasing is that the older population is now over 70%, 72%, and close to that for the 50 to 59s on 67%. So let's switch to the vaccine procurement, and very briefly, the slides are available so that people can get the trend of what happened. But the historical overview is that we have bought vaccines from 2 manufacturers, and we have also had other relationships with the COVAX facility. So the details are here. We started with procurement in February 21 and in June 21. And we have procured 11 million doses of Johnson & Johnson vaccine with a second amount of 20 million. And then the total number we've received is 19.6 million. And for the Pfizer doses, we procured 20 million doses and an additional 10 million at the time when the Johnson & Johnson vaccine was not available. So we had bought enough for 41 million people to be vaccinated at the time. And we've received donations from the US government during that time when we couldn't get Johnson & Johnson vaccine. So the bilateral agreements had upfront payments, and we have paid for most of the vaccine. I'll show some of it, which is still outstanding in a moment. And the down payments for Pfizer vaccine has all been settled. There's still some outstanding payments on the J&J vaccine to Janssen. In terms of using that vaccine, we followed this process. You've all seen this graph or layout before, so I'm not going to go into it. It's a fairly standard approach of how we approach the vaccination. I'm also not going to go through the details here, but for the record, honorable members can refer to the phase 1 when we were preparing the rollout. There were some significant changes as we learned more and more about the virus and the vaccines. And we are now in phase 3, where I'm going to concentrate my comments. So phase 1, just for completeness sake, is the listing of what happened during that period with establishing the capabilities across the health system, and includes the public and the private systems, and getting the launch of the Sisonke program, which was the flagship of phase 1. Phase 2 was the real rollout, which began on the 17th of May, where we started to get vaccines in larger numbers, and the vaccinators were trained. Eligibility for vaccination was still reasonably constrained at that time because we didn't have large numbers of vaccines, and we also didn't have huge numbers of vaccination sites that only started to increase during phase 2. So the process that was followed was in the public sector with dedicated large vaccination sites and the primary healthcare. We've had a very good program running with the private healthcare, which I'll talk a little bit more about in a moment. There was also the workplace occupational site processes, which have been very successful. And you will recall that in the beginning of the process, when we were struggling to get vaccine, we were eking out the vaccine in an essential workers program before we went into the age distribution. And then there have been very successful programs with the SASAQs to get to older people with the roving and the outreach sites. And all of this has been underpinned by the EVDS, where we collect our data. For completeness sake, we very quickly learned that we should use an age band rollout or an age cohort rollout, and these are the records of when we increased availability or eligibility to the vaccines. And then from November 2021, when it got more sophisticated and we started with boosters, as we learned more and more from the science of how the vaccine and immunity was working. Phase 3 is where we are now, and we remain, our target remains to reach 70% of the whole adult population, and to make sure that we focus on older people and the vulnerable groups. Those are mostly those with immunocompromised conditions. What has happened as the COVID has backed off on us is that we have integrated the vaccine program into the routine health services. There's still a single governance and management structure at the national level, with very good cooperation from provinces and still with the private sector, where we meet weekly. And we do have some upgrades of our health system to support the vaccination program in the sites that are available. We are trying to integrate the vaccination program everywhere into the clinical services at the primary healthcare level, and to make sure that as many as possible of the pharmacies and some of the other private sites remain. But we, because of the need to focus many of our personnel, both in the public and the private sector, back onto other services, we are prioritizing based on the data that's available, and that is on where the population is relatively under-vaccinated compared with the rest of the country, or where we know that there are large numbers of people who are vulnerable in those communities. The demand generation program is ongoing. There's still 120 local radio stations participating. The social mobilization is more at an individual community level, targeted at the priority districts and sub-districts. And we are using the data, including a geographical information system, to help us to target communities rather than do blanket advertisements and engagements with communities. So the challenge is, of course, that the demand for vaccines has decreased, despite the fact that we've only covered about 70% of adults. And the reasons are pretty similar to the rest of the world. We all have COVID fatigue. People are trying to get on with their lives after a very disrupted period, and they may believe that protection is no longer important. There's still quite a lot of vaccine hesitancy, largely brought about by conflicting messages that are on social media. And there are now practical barriers to accessing vaccines as the number of sites have reduced, particularly in the private sector, where it's no longer viable to keep vaccination sites open in the way that they were during the mass uptake. So our current strategies are to use the routine health services to focus on the congregate settings, including schools, workplaces, and to make sure that we focus on these low coverage districts, and to work very closely with the local communities rather than blanket messaging and blanket vaccinations. So just to pay tribute to our ministerial advisory committees, the Honourable Minister appointed 3 different ministerial advisory committees during the COVID, and those members have served tirelessly to, number one, support us in the whole COVID intervention and advice on what was happening in hospitals, in clinics, in the communities, and so forth. The Vaccine Ministerial Advisory Committee had their work cut out because things were changing all the time and we were learning more and more about the vaccines. And there was a Social Behavioral Change Ministerial Advisory Committee, which was helping us to understand why people were behaving in the way that they were behaving. Just to mention that the Vaccine Ministerial Advisory Committee produced 46 advisories during their lifespan so far, and that's because there was so much changing knowledge about both the vaccines and the way in which our immunity was responding to the vaccines available. We are now moving into a phase where National Health Council has advised that we de-escalate our COVID activities, and they've proposed, amongst others, that the Vaccine Ministerial Advisory Committee, the functions be moved into the existing National Advisory Group on immunization, and we deal with all immunizations together. There are some outstanding challenges with vaccines, and they've been there from the beginning. I think everyone's aware that we had a global challenge with Janssen, where there was problems in the Baltimore plant, and for a long period of time, we were unable to get any vaccine, any Johnson & Johnson vaccine. So the first shipments were thawed product, which had already been thawed for use in the United States. And that was what we were able to use in May, June of 2021. We then subsequently did start to get frozen vaccines from Johnson & Johnson, but it really only started to ramp up in September. So we had to change the vaccination program and rely more on Pfizer vaccine in the first months of the vaccination program. We were very grateful for the COVAX facility and the United States government who supported us during that time. Now we've got to the end of our relationship with COVAX now that we're not still procuring, with an outstanding commitment of 12 million doses, but we were able to negotiate with them to offset the United States donation of over 7 million doses against the outstanding amount, and we have now finalized that contract. So instead of being committed to an almost 1.4 billion rand, we are going to pay a donation into COVAX of 71 million rand to close the relationship with COVAX, unless, of course, we need to open a new deal if COVID becomes a problem. With Janssen, it's a bigger challenge. We have a commitment still to receive 11.4 million doses, and the balance of those still need to be paid for. We've been looking at all plausible options to mitigate this delivery for some months now by delaying deliveries and for trying to find donations. Nobody around the world is really buying vaccine at the moment, so it's very hard to sell them elsewhere. We've also, as I mentioned, had this very constructive relationship with the private sector during COVID, and that has meant a complicated reimbursement process. We had public sites vaccinating private people who are insured and on medical aids, and we've had private sites vaccinating public sector uninsured people. So we are busy with the reconciliation, and at the moment we're at a position where the private sector sites have submitted claims to the department of around 2 billion rand for public sector patients that they vaccinated at their sites. We have paid up to the end of August 992 million, and it's just over 1.08 billion by the end of September, and claims are still being processed at the moment. The public sector sites have also been paid by the private sector, by the medical schemes. Up to the end of the financial year, we had received 500 million rand, and up to this past week, in this financial year, we've received 824 million. So it's just on 1.3 billion that the private sector has paid for the public to the government for the vaccination of people on medical schemes by public sector sites. That's an ongoing process that will go for several months still as we finish the reconciliation on all of those vaccinations. In terms of stock, we have still got 8.6 million doses of Pfizer vaccine. Now, I will talk about expiry dates. This is a moving target, which is fortunate in some ways, but we do have 8.6 million and are only using around 30,000 doses of Pfizer vaccine a week. And we have 10 million doses of Johnson & Johnson vaccine in stock, and we are only using about 2,400 doses a week. Fortunately, the Johnson & Johnson vaccine's current expiry dates are only starting in June next year, and they run for a long time into September. Now, Just very briefly, the expiry and shelf life of vaccines is assessed on an ongoing basis around the world. And our regulator is also assessing the stability of these vaccines, remembering that they are quite new. We didn't know how they would behave. So they were originally, the Pfizer vaccine was registered for 9 months when stored at -70, and the Johnson or J&J vaccine at 24 months when stored at -20. But the ongoing stability studies have shown that, in fact, they are very stable. So they on every 3 months, we are so far getting extensions on the expiry date of these vaccines because they are not deteriorating. That's very useful to us. Lastly, on the vaccines, we are still trying to make these excess vaccines of ours available to elsewhere in the world. It's not as simple as it looks because many countries are donating, and there's a glut of vaccines in the global market. And most of the countries who would accept donations are unable to manage the Pfizer logistics. It's very difficult to manage vaccines at that kind of temperature, especially in African countries where it may be hot and vast distances need to be traveled. There's also a complication that when we donate vaccines, the receiving country or the receiving agency must accept the responsibility for the no-fault compensation, and most poor countries don't have that. So we are working with all the global and African bodies available to us as potential channels for donating vaccines that we are not likely to use so that they can still get into arms around the world. We do know that these vaccines' safety and potency are better and more stable than we thought before. So that is extremely encouraging. And destruction of vaccines anywhere in the world is always a last resort and will be for us as well. So in conclusion, Honorable Chair, the COVID-19 pandemic has settled for now. But we are still seeing the virus in circulation, and it has not gone away. This is a very fickle virus, and it's been unpredictable up to now. So we're not exactly sure how it's going to behave going forward. People are still getting sick, and although it's not in the large numbers and not as severely ill as we've seen before, there are still people being hospitalized, and there are still deaths being reported from COVID. And there's also the question of long COVID. So despite all the uncertainties and challenges, we have at least 50% of the adults that have been vaccinated. And we know that vaccination, especially if we boost immunity using repeated doses of vaccine, is still the most effective tool against COVID-19 infection. That we have procured vaccines in quite a hostile and competitive global market, and we live with the consequences of those very one-sided contracts, and we're trying to manage them as best we can now. The demand for vaccines is extremely low all over the world because people perceive the threat to be lower. And some of this, the result of this is going to mean that some of this vaccine is very vulnerable to expiry. But fortunately, the mitigating factor is we know that they are very stable. So our last parting shot would be a plea to the public, please to get vaccinated, to continue to get boosters. They will in the future be available every 120 days until we know that the virus is not in circulation anymore and we get the lifting of the global pandemic. Thank you.
Thank you, Dr. Chris. Honorable members, I see you have raised your hands. We have to have an understanding of whether we are going to take hands now or we are going to receive all 4 presentations and then ask all of our questions. I'm just concerned that we might concentrate too much on the one, or I would keep quite a good timing as to ensure that we don't spend too much time on one presentation and not be able to attend to the others. So let me take the hands I have seen.
Chair.
That could have to do with something else. Honorable Gela, yes?
Yes, Chair. I think, Chair, I want to second your proposal that we take all the presentation, we note our questions, and then after the presentation has been done to us, then you can allow us to to ask questions in all the presentation that will be made. I fully support that, Chair, to save time.
Thank you. Honorable Wilson.
Thank you, Chair, and forgive me if I don't put the video on. I'm in a very, very unstable area as far as connections are concerned. Chair, I hear what you're saying, and you know, already I have a couple of questions on this particular matter, and I have no doubt that my colleagues on the portfolio do as well. I just want to avoid a situation where we get to the end of this meeting after 3 presentations, and we're all going to sit and overwhelm people with 10, 20, 30 questions, whatever it is, after 3 presentations. I think perhaps it's a good idea to actually do this particular presentation as it stands now.
Honorables Munyai, Kaba, and Van Staden, in that order. We shouldn't waste time on this topic, honorable members.
Honorable Chair, I agree with your proposal and I support what you have said and what Honorable Geller said, such that the question must be at the end. Otherwise, we must have comprehensive presentation, which I think it may not be long in my view. So I'll appreciate that view.
Thank you, Honorable Kaba.
Chair, I think Honorable Geller and Munyai had already said it. I think for the members, it's important to understand that we really need the holistic presentation from the department so that we are focused and then we then answer. We don't ask all questions. I support that, Chair. Thank you.
Honorable Van Staden and then Honorable Chirwa.
Chair, I think we should have sorted this out before this meeting. Forgive me for not using my video, but I want to support Member Wilson on this. I think it will be the best to do a report, get the questions, get the answers, and move on to the next one. We have asked for a longer meeting than this one, what was scheduled for today, but unfortunately the program of Parliament interrupted us today. But I want to suggest also, if we don't get through this program, that we set up a meeting as early as the day after tomorrow. Thank you, Chairperson.
Thank you, Honorable Chirwa.
Thank you, Chairperson. I support the recommendation that we get all the presentations and then ask the questions afterwards. It's going to save us time. It's going to give the department more time to answer. So there's no excuses of the fact that time is running out and stuff like that, like they usually do. So yeah, all the presentations and then they can answer afterwards.
Thank you very much. Honorable members, I'm going to agree and I've proposed that we get all presentations. I've looked at the presentations. They're not so long. The other 3 presentations, we've allowed 1.5 hours for presentation. I think we're probably going to use only 1 hour, meaning we would have more time for discussions and engagements. So, Honorable Minister, thank you very much for that presentation. You may go on to the other 3 presentations and just follow them in that order, and we will take all questions at the end of the 4 presentations.
Thank you very much, Honorable Chair. The next one will then be on where we are with the health regulations, which will be done by Dr. Tulare. Just before she comes, just to conclude on this one, to alert members that, as Dr. Crisp indicated, for the first time we had this integrated system of public and private, being able to use all public and private facilities. There is a complex, as he reported, process of reimbursement. We will obviously come back when we do our annual report, just to alert members that we've got some difficulty with the Auditor General on the reimbursement in terms of certainty of whether we will be able to get the reimbursement in full from the medical aid schemes, because some claims have been queried in terms of whether the people who are supposed to be covered are still on medical aid cover. So that's a matter which is likely to give us an audit query as they are concluding the audit. Just to be aware, that matter will be discussed, I think, in future when we discuss the annual report. But Dr. Tulare can then come through to present where we are with the regulations. Thank you.
Thank you, Honorable Chair. Thank you, Minister, and thank you, Honorable members of the Portfolio Committee. I am going to present on the update on the health regulations. There were 4 health regulations that were published for comment on the 15th of March with Gazette number 46048. And we had amendments and an extension on the 15th of April on these regulations. The regulations relate to those that are on surveillance and control of notifiable medical conditions, those relating to public health measures in points of entry, and regulations relating to the management of human remains, as well as regulations relating to environmental health. After further consideration, the comment period was extended by 3 months from the 5th of May to the 5th of August 2022 through Government Gazette 46319. As of the closing date of the extended period of comment, which was the 5th of August, a total of just under 400,000 public comments were received, the exact number being 394,931, but we are still finalizing this number because there were some comments that arrived after the comment period was closed, and they are still being considered for finalization to include in this number. Just also to reflect that the 4 regulations have been subjected to a socio-economic impact assessments study as per the requirement of the Department of Planning, Monitoring and Evaluation. And these SAYAs have been submitted to DPME, who has evaluated the SAYAs, and we are waiting for final approval based on comments that were received from DPME to fine-tune the SAYAs. Just lastly, honorable members, to indicate that the finalization of these regulations is guided by provisions of Section 90, 4A and B of the National Health Act, which states that in processing regulations, the minister must publish all regulations to be made under this act in a gazette for comment for at least 3 months before the date contemplated for their commencement. And if after the publishing of regulations, the minister alters the draft regulations as a result of any comments, he or she need not publish those alterations before making the final regulations. So the process of finalizing the regulations will be guided by this provision in the National Health Act. And as indicated previously, we are in the process of analyzing all the just under 400,000 comments that have been received, and we are following due process, also in line with the guidance that comes from DPME. I thank you.
Thank you very much, Dr. Tulare. Honorable Chair and members, just to indicate therefore that as things stand, as members will be aware, the interim regulations which were used were all lifted on the 22nd of June. So what prevails currently in terms of the control of notifiable medical conditions is the regulations which were gazetted in 2017. So the 2017 regulations in terms of notifiable medical conditions are the ones which are in operation as we speak, because all others which were gazetted specifically for the control of COVID were lifted on the 22nd of June. Thank you very much, Chair. If we are allowed, we can proceed with the next presentation. Dr. Crisp will come back on the monkeypox.
Yes, you're welcome. Thank you, Minister.
Okay, Thank you very much, Chair. The host has disabled my screen sharing, so if you can, thank you. Okay, thank you very much. So that we'll keep this very short, but just so that everybody is on top of what monkeypox is, it's a condition that presents with an unexplained acute rash or skin lesions and one or more of a range of symptoms which are quite generic, like headache, acute onsets of high fever, lymphadenopathy, which is swollen lymph nodes, muscle body, backache, and where other diagnoses of similar looking diseases have been excluded. And then it can be confirmed in a laboratory diagnosis. Since January 2022 to the 19th of September, there were over 61,000 laboratory confirmed cases across the globe. And you will see it's very widespread across all of the regions of the WHO's regions, but concentrated in the Americas and Europe, with Africa only confirming 587 laboratory confirmed cases, which is, normally Africa is the endemic area. So it's because it has spread across the world that it has been raised in stature. In South Africa, since the 22nd of June, when the first case was identified, and up to the 21st of September, there have been 5 unlinked laboratory confirmed monkeypox cases reported with no deaths. Now, when we say unlinked, they're not related to one another in any way when they have been investigated. And there have been no new laboratory confirmed cases reported since the last case on the 17th of August. And those cases that were reported were 1 in Limpopo, 2 in Gauteng, and 2 in the Western Cape. And there have been no secondary cases. In other words, when they've been followed up to see the contacts and people who may have lived with and been closely associated with these 5 people, there have been no secondary cases. From the 21st of May to the 25th of May to the 21st of September, the NICD, which is responsible for reporting on the public sector's laboratory results, conducted 382 PCR tests. The bulk of them were South African, but also from other African countries. And this number does not include the tests that were done in the private sector, where some other cases have been picked up in the past. But the numbers are quite big, larger numbers of tests done compared with the cases being identified. And the genome has been examined of this virus, and it is the West African clade, which is what's called a BA1 lineage. It's technical information, but it means it's not a new virus. It's a known virus, which is well described already in Africa. So the last slide is just to say, what are the actions? Globally, the action was on the 23rd of July, the WHO Director General declared this outbreak as a public health emergency of international concern. That's different from a global pandemic. But what it does is it puts in temporary recommendations for all countries so that we work together as a globe to try and stop the transmission of the virus to areas where it has not traditionally been seen. Several actions have been taken in South Africa. We work closely with the WHO, both here in the country, also the Africa office and the head office. And we have a national risk assessment that has been done. WHO has mediated a gap analysis for us to look at our capabilities for containing the virus. And there's a multi-sectoral action plan that is managed by the NICD for the country. And we work very, obviously, being an agency of the department within the National Health Laboratory Service, we work very closely with the NICD. So far, there have been quite wide discussions around whether there's a need for monkeypox vaccines. It's been looked at by a number of different academic bodies and advisory committees, and we are not vaccinating for monkeypox. At this point in time, it's not necessary in the country, and the vaccines are not readily available in the global market right now anyway. So what we have done is taken steps to improve surveillance and to make sure that all non-government organizations, public sector, private sector, are aware and clinicians around the country are aware so that testing can be done if somebody comes, presents to those clinicians with symptoms which look suspicious. Thank you.
Thank you, Dr. Crisp. We will receive the next presentation, Minister.
Yeah, thank you very much, Chair. Quite brief. The last one then will be on the backlogs on surgical operations. Dr. Makanya, you can come through.
Good morning, Minister, honorable members. Could I be allowed to share the screen unless... Oh. Okay. Thank you. My presentation is on backlogs on elective surgeries. And the purpose of the presentation is to provide a progress report on the interventions regarding reduction of elective surgery backlogs in hospital and in the country.
Natlanta, can you go on to slide mode so that it's more visible?
Thank you, Minister. My apologies.
Yeah, that's fine. Thank you.
Thank you. And the backlogs on elective surgeries have been building up over the past 2 years and a half, primarily due to the impact of the pandemic, thus threatening quality of life for the affected patients. There was a moratorium on all elective surgeries to accommodate influx of patients due to COVID-19. And this has already impacted on the increased number of backlogs. The moratorium on elective surgeries, however, was lifted in 2021, and a plan to accelerate backlogs was put in place, as well as measures to deal with emergency surgery and electives concurrently. Disciplines that are presented below are those that have been highly affected and with high numbers of backlog. In total, number of backlog received from provinces for the period that started in June, the period that is between June and August 2022. These are updated frequently to monitor the impact of the interventions. So these are the backlogs per province, with a total backlog of 175,024, and a backlog in each of the provinces are highlighted. And the disciplines that are highly impacted are also listed, and mainly the orthopedic and the types of surgery are fractures, knee replacement, knee and hip replacement. And the total waiting time for these operations range between 2 weeks to 7 years, depending on an institution. And within the obstetric and gynecology discipline, it is hysterectomies in the main, and their waiting period range between 2 to 2 years. General surgery backlogs primarily include thyroidectomy, endoscopy, colostomy reversal, removals of lump, and keloid extraction, as well as ileostomies. And the waiting period for the general surgery is 2 weeks to 2 years. With ophthalmology, the main backlog is around cataract extraction, and it is up to 3 years. With urology, it's mainly prostate and hydrocele, which range between 6 to 12 months. On oncology, the backlog is high amongst mastectomy and other cancer and other cancer-related surgeries, and the waiting period in this regard range between 1 and 2 years. With cardiothoracic, main types of surgery includes lung, thoracic, and related surgeries, and the waiting period is 6 to 18 months. And lastly, the discipline with a highest waiting list is plastic surgery, which include breast reduction, repairs of hernias, and other cosmetic surgeries. We have really looked at how provinces have actually tried to deal with the backlog in terms of optimizing efficiencies. And what is highlighted here is a summary of interventions that are cross-cutting amongst all provinces. And mainly was the lifting of the moratorium on elective surgery, which was done in 2021. Thank you, Chair. And all emergencies are prioritized. The hospitals have rescheduled all non-emergency operations and providing theater service during the weekends and extended hours to reduce backlog. This includes increasing theater time even during the week. There are provinces are conducting outreach surgical teams to provide services in most provinces. And there's also use of private hospital theaters through a dedicated grant using a private-public partnership initiative, particularly on those surgeries that are related to cancer. Patients, again, are booked 6 months in advance, as well as according to capacity that is available and the threat to quality of life. The waiting list is consistently being reviewed, and monthly monitoring of the waiting period is done across all facilities. All facilities have also maximized their theater use by increasing slates, theater operating times to include weekends. And there are also some provinces who were able to actually add more theaters to be able to provide more services even during weekends. These initiatives have been achieved by making sure that provinces actually look into human resources that are related to this, and most provinces are recruiting specialists so that they can be able to increase their output in terms of managing the backlogs in hospitals. Honorable Chair, then we've also lifted what is specific to each of the provinces over and above those that are common amongst all provinces. For instance, in Eastern Cape, the hospital have rescheduled all non-emergency operations. Free States are conducting marathons that are arranged immediately. The department notices an increase in backlog. And they also educate their patients to ensure that they keep to their appointments, because at times when patients have been scheduled, they don't turn up on the date that they've been scheduled for. And there's also a team on call for emergency theaters. In Gauteng, again, they also have a team of volunteers, particularly orthopedics and anesthetists, that are drawn from other provinces to form part of their outreach teams, the outreach teams that are common in most provinces. They do their booking electronically, and they've repurposed COVID wards to increase post-operative care space, and they have dedicated specific catch-up days to be able to do specific backlogs, particularly the surgical cataracts. They're also rescheduling of elective surgeries, they are also planning to increase the number of high care unit beds. They've also managed to actually address issues of staff shortages, and vacancies have been to fill the vacant post, and the recruitment processes is underway since April to fill the critical vacant post related to theater activities. They've also appointed a dedicated clinical manager to oversee all their 46 theaters as means of improving their efficiency. Overall, beefing up of human resources also include Gauteng having appointed as a sessional specialist and nurses through nursing agencies. They've also renovated theaters to increase the number of functional areas, and contractors are sourced to repair and maintain tunnel washers, and the contractor has been appointed to repair and maintain the autoclave. The highlights in KZN is around the camps that are conducted on weekends to be able to deal with the backlog of cataract. Additional half-day theater is planned for every Thursday to expand the space. No waiting for emergency or malignancies, as these were done all under emergency slate. So they don't have any waiting, so there's no waiting for any emergencies that are related to emergencies, because the emergency slate is retained despite this despite this initiative to deal with backlogs. No new dates are given, but electives are called back according to priority and bed availability. In Limpopo, there is a group of in-house specialists and volunteers from other provinces. They visit a district at a time to conduct elective surgeries in obstetric and gynecology, including hysterectomy. In general surgery, there's a team of surgeons conduct mastectomy and thyroidectomy, and these are done on quarterly basis. From May 2022, monthly outreach services under the theme framed Rural Health Matters. For urology, they also do prostate and hydrocele. In orthopedics, they do hip replacement and knee surgery and pediatric surgery, and also maxillofacial and cataract extractions. And there is also specific month focus. The specific month focus is the program that was set for 13 to 21 August in Waterberg district, where 428 surgeries were conducted. In Mpumalanga, they also do they've increased theaters for theater time for doing cataracts to 2 days per week. Operationalization of the 7 theaters and 2 emergency theaters. And they have also developed and are implementing their marathon plans over the weekend. And they are headhunting a second orthopedic surgeon for the province, and as well as an ophthalmologist. And in the month of October, they are planning to have an ophthalmology marathon, and they are in the process of recruitment of the general surgeon. They are also currently in the process of recruiting the general surgeon. In Northern Cape, the tertiary hospital conducted outreach service where minor orthopedic operation in the district hospitals are performed, and these are done in Uppington, KZ Matthew, and in DR. And there are also the recruitment of specialists, especially anesthetists, that are required during operations. And in Northwest, their outreach program is framed surgical bleeds, and they are also providing theater service during weekends and extended hours to reduce the backlog. And there is also utilization of all available theaters to improve efficiency. And they also engage in public-private partnership where it is feasible. In Western Cape, the province allocated an additional of 20 million from internal prioritization of funds to deal with the backlog. And then the province is also increasing day surgery activities as far as possible, and this will assist in dealing with the backlog. And the province also procured 2 surgical robots at the cost of 80 million, and this will reduce the recovery time and allow patients to be discharged early. I thank you, Chairperson and honorable members. Thank you.
Thank you very much, Dr. Makanya. DG, Anything from your side? Otherwise, we hand back to the Honorable Chair. Any addition from DG?
No, thank you very much, Honorable Minister. I think I'm covered. We are ready to deal with the questions. Thank you, Minister.
Thank you very much. Back to you, Honorable Chair.
Thank you, Minister, and DG and DDGs and acting DDG for those presentations. I am looking at the hands which are raised, honorable members. I only see the hands of Honorable Wilson and Clark, Sukas, Van Staden. I'm going to repeat: Wilson, Clark, Sukas, Van Staden. Any other members who want to raise any questions with the Minister and the Department?
Chair, my hand is up. Honorable
Ismail.
Ismail.
Any other members? Just before I take those hands, honorable members, I want to take this opportunity to congratulate the department, the minister, government, with the work performed during the COVID-19 pandemic, and also with the rollout of the vaccines to the people of South Africa. We noted that at least 50% of all adults had received at least one dose of vaccine. We also understand that there is this demand generation program, and we need to motivate our people to go for the booster doses. We are also understanding that some of those doses would possibly, or those vaccines could possibly expire in the future. But that COVID itself is not gone. It's low numbers of infections on a daily basis, but that surely there are some people who still become infected with the coronavirus. I want to just put that at first, and then take the hands, and then at the end I will also raise some questions which I want to present to the Minister and the Department. So in that order, it's Honorable Clark's.
Chair, I was the
Wilson,
first one
Clark,
to raise my hand.
Staden, Ismail, Gela.
Chair.
Sorry, I didn't see your hand, Honorable Gela, but it's fine. I can give you the first space. Thank you. Gela, Wilson, Clark, Sukas, Van Staden, Ismail. Any other hands? Let us then discuss Chirwa. In that order, honorable members. Any other members who come on board, I will add towards the end. Honorable Gela, you may start.
Thank you very much, Chairperson. Good morning, Minister and the team of the Department of Health and the Deputy Minister. Thank you very much, Minister, for the report that is tabled to us as portfolio committee members. We really appreciate the report, the detailed report, the comprehensive report that you have tabled to us as portfolio members, so that we can be able also to happening. Coming to the issue that I wanted to raise, Minister, firstly, I want to go to the first presentation. My first question, Dr. Crisp, is that how many vaccines are due to expire in the next 2 months? And what is the estimated value of those vaccines when they are expired? If we can just get a clarity on that one, because in your presentation, you also mentioned the issue of expiring dates. Hence, I'm asking this question. Secondly, Minister, I think you know the issue of digital vibes, a saga that was all over. And also my question on this one, after the digital vibe saga, how many COVID-19 communication around a vaccine handled? How much was spent on communication and vaccine mobilization? That will be my question on this one. Thirdly, given the low demand, as Dr. Crisp has mentioned in his presentation, will the department still be obligated to pay for and receive the outstanding Pfizer and J&J vaccine ordered? Those are my questions on the first presentation. And also the other one, Minister, it's the issue of load shedding that is currently happening in the country, which it's having a negative impact. As we know that health is a essential services, and most we are using energy. And I just want briefly, what is the plan? I know that you have generators in most of the hospital, in the most of the facilities of health. Just any backup, maybe anything, maybe if I can just get on that. If we did that, I'm so sorry if I didn't hear anything regarding the load shedding, but I know it's also affecting the health facilities. Coming to the issue of monkeypox, which is another pandemic that is happening after COVID. Now it's a monkeypox. We are in trouble. But the question that I want to ask, Minister, is that what action have been taken to address the required imposed through the World Health Organization and related to the PHEIC of the monkeypox? The other question is that does the department have any vaccine for monkeypox, and is there a plan to procure or to produce vaccine for monkeypox if it's needed? Because I think we need also to be on board what is going to happen and what is the plan for the department regarding the monkeypox. Coming to the issue of health regulation, I've got only one question. We also welcome the presentation done by Dr. Tulan. But my question is that what are the potential cost implication of the regulations? That will be the only question in terms of a health regulation. And then coming to the surgery backlogs, firstly, let me also welcome the presentation, but my question will be what is being done to increase the number of theatre nurses, and how quickly this position will be filled when vaccine occurred? Because in your presentation, I think there is a need for the nurses to be increased in theatres. Coming to my last question, Chair, can the department update the committee on the current operational status of the Charlotte Maxeke Academic Hospital following the fire that happened in 2021? I know, Chair, as a portfolio committee, we went there or as a committee to see actually what happened in that hospital. But I think we also need an update so far, the progress in terms of when the hospital it's going to operate fully. Thank you very much, Chairperson, for the opportunity, and thank you very much, Minister, for the update. and the good work that you are doing. Thank you very much with your team. That's all from me, Chair.
Honorable Wilson. Thank you, Honorable Geller.
Thank you, Chairperson. So I have a few questions. I'm going to start with Dr. Crisp's presentation on the vaccinations. What we don't get anymore, and what we as a portfolio are not seeing anymore, is the current status of COVID patients. We used to get that daily. Now we're barely seeing it at all. And I think this has become critical, that we need to have some kind of regular update. How many current cases of COVID are there and how many deaths there are, and particularly those deaths related to people who have not been vaccinated. I think we need to differentiate between deaths and people with comorbidities. And I raise this because I've recently, in the last few months, lost 3 friends due to COVID. 2 were not vaccinated, never had vaccinations. The other one was as a result of comorbidities and a severe heart problem. But I think it's very important that we have access to those kind of figures, and we're not getting them on a regular basis, and it's concerning because I think people need to know. You were talking about people sort of moving on with their lives and thinking that COVID's over and all of that kind of thing, and it most certainly isn't. And I've had experience of this in the last couple of months. But we're not advising the public of the current status and what is happening. And we need to bridge the gap between lack of information and encouraging people to do what they need to do. We were talking about booster shots. Now, I know a lot of people who've had the 2 first vaccines or the 1 first vaccine, but have never ever gone to the booster shot. That's number 1. Again, because of the lethargy around vaccinations and lack of information. There are also a lot of people I know who've had COVID. And mostly in the mild form, a week at home and they quickly recovered, including my own family. But now they believe that because they've had COVID, they don't need to do anything further. They're not compromised anymore. They have an immune system and they're not going to do these things. And if these things are necessary, we need to be advising the public that should be happening. And in actual fact, that you can get COVID 2 or 3 times. And I have been witness to that myself. I'm glad to hear that you say we're no longer procuring vaccines. That's all very, very well and good, but we are paying for vaccines that we're not using. And I think this is very, very alarming. Now, I know we can't offload that to other countries because the rest of the world is not procuring either. But when we're wasting, my question is then, did the system work? Were we using the right information? The fact that we are sitting with all of these vaccines that we have to pay for that are not being used tells me that somewhere along the line in the organogram or in the structures, we weren't on top of the situation. Otherwise, we wouldn't be sitting in the situation we are now. And if we are sitting with those vaccines that we can't use, then we need to put something in place to make sure that people go and take up those vaccines. And I don't think enough is being done with that regard, i.e., you need the booster shot, i.e., people are still dying because they're vaccinated, i.e., if you've got COVID, if you've had COVID, you still need to continue with your vaccinations. People are just not, because they don't believe it's necessary. And I think more needs to be done in that regard. Dr. Tulani's presentation, the only thing I have to say on that, Dr. Tulani, is, it's all very well to talk about alterations to the Health Act. And we look forward to seeing what those are. The fact that it's going to be published without any other consultation, or can be published without any other consultation, is very, very concerning to me, particularly if those alterations or amendments to the Act are made, and they are in contradiction or could be in contradiction or contravention of Section 27 of the Constitution, which states very, very clearly what the rights of people are. And I just, in other words, the imperatives of Section 27, and I read this from the Health Act, should not be seen in isolation, but a necessary part of the achievement of all rights in the Bill of Rights. Importantly, the right to equality includes the full and equal enjoyment of all rights and freedom. And that, I think, was one of the main concerns about many of the public comments that we received, that we referred to the platform for comments, is that we are going to overstep Section 27. So we look forward to seeing that. But my concern is that it could be published before we have access to that. And I think that that could be problematic. Dr. Chris, monkeypox. I have 2 grandchildren who just had chickenpox. And at no stage, and I mean, they sort of didn't undergo sort of any rigid testing or, let me just say the doctor took one look at them and said chickenpox. Are our doctors aware enough of what monkeypox is and what the indicators are, or how it should be dealt with, or what should be tested and what shouldn't be tested? And I just raise this because I've just had 2 children with what they refer to as chickenpox. It wasn't bad. It was over, within a few days. But the doctor didn't even raise monkeypox. I'm just concerned about the awareness of our medical structures as to what monkeypox is and how it spreads and all of those kind of things. And then lastly, on the backlog of surgical procedures, well, I'm absolutely horrified. I'm gobsmacked about the situation. And again, I'm going to raise Section 27 of the Constitution. People have an access to quality healthcare, and it's just not there. Orthopedic surgeries, 2 weeks to 7 years. Well, I'm sorry, not acceptable. Not under any circumstances is that acceptable. People who need knee replacement, hip replacements, and other replacements are living in extreme pain. A lot of them end up in a situation where they are unable to walk, who are on crutches or walkers or in wheelchairs. They are living with pain. They are unable to function normally. They are losing their jobs as a result. They're taking time off work because of the pain and agony that they're going through. This is not just impacting health. It's impacting the quality of life of our people. It's affecting jobs. It's affecting infrastructure, people not being able to work optimally. It's just horrific. And cancer and oncology. Well, I'm sorry, 1 to 2 years backlog is a death sentence. It is a death sentence. We know what cancer does. We know how it works. And if it is not treated very, very quickly, if tumors are not dealt with, removed, mastectomies done, the chances are very, very good that these things will spread very, very quickly. That's how cancer operates. We can't even, Limpopo has 1 oncology section for an entire province that's running, that's just for chemotherapy and radiation. That's running so far behind, it's frightening. Now, I'm sorry, that is direct contravention of Section 27 of the Constitution. It is unacceptable. You're saying to people, sorry, we can't help you. The likelihood is that this could spread and, yeah, sorry, you could die. What kind of message are we sending to our people? I'm absolutely appalled. I'm absolutely appalled. We have a shortage of surgeons. Theatres are badly supplied. They don't have the correct infrastructure. A lot of our surgeons, and I know many who could assist, say they won't. They will not work in a public facility because of the lack of infrastructure, because they cannot do what they're supposed to do in a proper manner in public theatres. And they are not going to subject themselves to medical legal claims. And we know where we sit with that already. And I mentioned it in last week's meeting at a hospital in KZN, when a doctor was removing a cyst and actually removed the bladder and not the cyst. Dear God in heaven, where have we got to? It's just not acceptable. There is no water in half the hospitals in Limpopo. We are Jane First is relying on trucks that are coming from Marble Hall, from Ephraim Makali for water. We've been to several hospitals. The generators are not working. They don't have money to keep those generators operating when they are functional. I'm sorry, I don't know how we got to this, and we cannot just blame COVID. We cannot just blame COVID. This started long before COVID. The health system is collapsing. And this backlog of elective surgeries is absolutely appalling. And I hate to tell you that you are going to face huge human rights issues and court issues on this. You cannot sit back and say, well, we can't help you for 2 years when you've got cancer. And yeah, sorry, we can't help you, must just die. It's just absolutely disgusting, appalling. I'm shocked and I'm embarrassed that we are sitting in this situation in South Africa. Thank you, Chair.
Honorable Clerk.
Thank you, Chairperson, and thank you to the Department and the Minister for the presentations. I'd like to ask the following questions. What are the costs of the vaccines that will be destroyed at the end of October versus the total loan we took out to cover the costs when we purchased? Then 32.6% vaccinated. What additional programs are put in place to create awareness? And I know Dr. Chris spoke about programs, but are we still using local clinics? And in particularly, what programs are we putting in place to target the younger generation? Because that seems to be the lack of interest. And then I'd like to know, what is the status in terms of the fraud and corruption cases during COVID-19? I would really ask the Minister if the SIU would come and present the report to the committee, Chair. And then have we done any investigation? Because there have been recent articles in the newspaper saying there's certain side effects that affect younger people in terms of the vaccination. So look, I mean, I'm a firm believer it's up to you to take the vaccine. It's your responsibility, and you should be acting responsible. We should not make it mandatory at all. I myself has been vaccinated and boosted because I believe that's the best for myself. Then in terms of upgrades of programs, as mentioned, I mean, what are those programs that Dr. Chris mentioned, that there's upgrades in terms of these programs? And then is there any indication what kind of immunity rate we have in the country in terms of COVID? And what plans are in place if we experience another surge in COVID? Then what was the indicators that were used to procure such large-scale vaccines? You know, how did we gauge in terms of the procurement we did? And now that we have this huge amount of vaccines that are going to expire shortly, and how is the department addressing the backlogs on TB and HIV? Because I don't think there's been much focus put on that while COVID was in place in the country. Then in terms of the regulations, we requested an audit on the objections because I had sent through many cases of proof where objections were deleted off the system, and I think that's a very big concern for us. And then, you know, as a member Wilson had said, it's very concerning that we won't see once the process is finished, what the regulations are actually going to look like in terms of what the public would be subjected to. And there must be some clear indications in terms of the differences when it comes to NMCs. For example, COVID is very different to lead poisoning. And, you know, those are the things that we would like to see if those regulations are published. And also, you know, we do not want to see regulations published to make sure, you know, to sort of guide South Africans that they are now, their freedoms are limited in terms of a police state, and that's certainly not what we want to see in terms of these regulations. Then in terms of monkeypox, member Wilson covered me around the awareness around that. And then in terms of the interventions you've put in terms of the backlogs, which I have to say to you is absolutely shocking. And Minister, I would suggest you get a team of people on the ground and to go and visit these hospitals, because firstly, the stats that have been indicated in the presentation are completely skewed. They're not correct. I have spoken to many of our guys in different provinces, and what your presentation says in terms of the stats and what the real situation out there is completely different. There are far larger amounts of backlogs than what is shown in your stats. And I must tell you that, you know, when I visit hospitals on the ground, there are huge problems in terms of why we're sitting in this situation, and interventions that have been given in this presentation is certainly not going to address these backlogs, I can assure you, because we just firstly do not have the infrastructure. Many of our theatres are not working at all. I mean, we saw last month at Pelanomi Hospital, our surgeons just resigned in droves because they could not get any operational needs that they needed in order to do the surgery they should be doing, and they just could not stand working in that environment anymore. And this is happening in many, many hospitals. The shortages of doctors and nurses versus the procurement system that takes forever. I can't see how we're going to employ X amount of medical clinicians that we need in a very short period of time, because our HR procedures are so lengthy, and we just can't get people employed. It takes over a year. If you see all the vacant positions on the hospitals presentations that we've had, and how long it takes to actually employ people. Then in terms of procurement processes and paying service providers, I mean, you just see every day that service providers are not providing to the hospitals because they're not being paid. So, you know, a lot of those things need to be sorted out before you can even address these backlogs, because if you don't address these things, you're going to be fighting a losing battle. You've got huge shortages in terms of ICU. Many hospitals don't even have ICU units. And then I would like to know, what is the grants per province and agreements with the public partnerships versus your success rates? Because many surgeons, as Member Wilson said, many surgeons in private practice are saying they're not going to work in state hospitals because of the environment they need to operate in, and they're not going to be liable for any medical claims if anything goes wrong. Then in terms of load shedding, I mean, you know, most hospitals you go to might have generators, but most of those generators are either not working or they just simply do not have the budget in order to fuel them. Let's go to the next lot. And then you speak about electronic bookings. Now, many hospitals I visited don't even have computer systems. So I don't know how you're going to manage electronic bookings within hospitals in terms of these surgical cases. You also speak about projects and renovations that you're going to be doing. And I mean, how are you going to ensure that those projects actually take place in a legit manner? Because I'll give you an example. Pelanomi Hospital was supposed to build a neonatal theatre for the neonatal unit. And 10 years down the line, that project has still not been completed. So, I mean, if you have that kind of management in terms of project management, I just can't see that you're actually going to bridge this problem. And you know, are we ensuring that these projects, we're going to have proper project managers on board to make sure that we have skilled contractors on board in order to execute what needs to be done? And then, I mean, we talk about strengthening plans. I mean, how are you going to strengthen those plans? And then also in terms of the district hospitals to deal with surgery, I mean, are there any plans in place to look at that and to capacitate district hospitals in order to deal with surgery in terms of infrastructure and in terms of staffing? Thank you.
Chair, shall I continue? I take it I'm just after Honourable Clark.
Yes, please do.
Thank you, Chair. Let me just as a courtesy say to the department and to the Minister, thank you for the presentation. I have a few questions. I want to start that is linked to this presentation, certainly the loan that was mentioned. And I do apologize if there was any presentation made concerning the loan to the committee, as I am an alternate member and I may have just missed some of it. But if so, then certainly the chair can just correct me in terms of that. The loan that was taken out to the value of 7.6 billion rand was said that it was to curb the spread of COVID. Now, I have a few questions in terms of the loan first, and then I will move to the rest of my questions. The first is, this loan will be used to restructure debt. Who holds the original loan and at what interest rates and terms? Secondly, in what ways is this World Bank loan better? And then if you could tell us what fees, if any, have been paid to third parties to secure and structure this loan, and what fees or penalties are being paid to the original lenders to settle our debts, and who are those third parties? And then fourthly, what is the term of the new loan and by when will it be paid off? Now, linked to the questions on the loan, the issues that was raised by both Honorable Wilson and Clark, right in the beginning, when we first had a meeting with then Minister Willem Kiese, one of the gaps that we, from the onset, highlighted in the committee was the issue around strategic procurement. Now, there are two things that are very worrying. The first is that today we are having a presentation on COVID, monkeypox. Certainly with monkeypox, we need to know this. But we are in the middle of a health crisis, and it is a crisis that is not being blown up by politicians. It is one that we are being made aware of, certainly by people that are working on the ground in our provinces, our respected medical doctors, surgeons that are blowing the alarm and saying that they cannot deal with this. This is a committee of parliament that has oversight over the department. There seems then for me to be this view that we have a lopsided focus here, because firstly, the issues as it relates to the health crises and the procurement issues that are not linked only to COVID, but those things that are impeding services in the hospitals, that are severely undermining quality of healthcare to South Africans, we as a committee are not being addressed on those. And so I want to really say to the minister, it is imperative and it is our constitutional duty as parliament for us to hold the executive to account and to get answers on the issues that are pertinent, critical, and urgent. Not that COVID is not, as certainly we hear from Honorable Wilson, it still does affect people. But we need the answers. We need to know now, not tomorrow, not yesterday. We need to really know what is being done holistically. My question then is, are we waiting for NHI framework, the legal framework? Are we waiting for that to be completed before we fully deal with the crisis? I'm certain there are no easy answers, and we have a doctor here that is chairing this committee. There are no easy answers, we know this. But certainly in any business, there are things that you can do that are quick and easy. Quick and easy doesn't mean it's not complex. But we need to know what are those things that you are going to do. Because to us, and to me certainly, it looks as if we are waiting for NHI, we are focusing on COVID. And it is not good enough. And so for that reason, I am putting it to the minister, and I'm certainly asking the chair, that it would be amiss of us in our constitutional duty to not get the answers that we need. In my constituency, we are sitting in one night, not just once, not twice, the whole of last year and certainly before, where there was a shortage of ambulances, where I was told that there was triage for ambulance, that if people are over 70, they will put them last on the list. And the most urgent, they will look at in terms of age or in terms of condition. Those things are very serious issues because like Honorable Wilson has said, those are constitutional issues that we, all of us sitting here, we are bound by that constitution. So we need answers on those critical matters. And we need answers in terms of the terms of the loan. In terms of strategic procurement and the gaps that I've spoken of before. The private sector, in fact, South Africa, the FMCG sector, are one of the most expert specialists in terms of procurement on scale. I asked the question and I got a very arrogant answer right in the beginning in terms of procurement. It is now very open to all of us, whether you be a layperson, have no idea of procurement, we now can see your system is not working. You've made a serious blunders, you've not connected supply, demand, behavior, all of those things, which is being done within the private sector. Why is it that you have not done that? Because you've said to this committee that, yes, we've got the specialist knowledge. Yes, we've got that. You've got an oversupply. You've made a loan. We need to understand, like I said, the terms of those loans. Then I want to move to the issue of monkeypox. The spread of monkeypox is linked to behavior. What is being done in terms of, first of all, messaging? We failed dismally in messaging when it came to COVID. We are 3 years into living with COVID. We still have not done anything. I don't get it on the radio. I don't get it on television. Nobody is putting emphasis on the links of comorbidities and the severity of the disease. Again, we've got a huge loan for vaccination. We have absolutely no indication of a comprehensive communication strategy as it links firstly to monkeypox now, to COVID, and then in terms of treatment. Chair, I'm not going to take long. Just is my last question. And this is, as part of the MAC, the MAC Advisory Council, I think it was in last year, in the middle of the year, I'm not sure, the beginning of the year, where a social behavior specialist or expert was brought onto the advisory committee, specifically to deal with the issues of behavior. My question is, what is the cost of the MAC advisory, if any, to the department? And in terms of that social behavioral expert or think tank that you have there as part of that, how is that being utilized specifically now with monkeypox? And is it going to be extended to the issues of people specifically with issues with HIV and AIDS treatment fallout? There may be, of course, I know this, it may be part of some other program, but I just want to know, how do you utilize going to expand it in order to deal with the other?
Honorable Sukkers, I was about to ask you to wrap up, and then I hear your network is not doing so well. I think I've given you a lot of time, Honorable Sukkers. I'm going to move on to the next Honorable Member, Van Staden.
Thank you, Honorable Chairperson. Yeah, if I can quickly touch on the vaccines, it seems to me that government doesn't have a good business sense at all, because I can't understand why you would still have an outstanding amount of 71 billion rand on a COVAX contract of 1.4 billion, which we were supposed to receive 12 million doses, but out of us 12 million doses, we only received 1.3 million doses. That doesn't make business sense for me at all. But nevertheless, I would just want to touch on the health regulations as well. Out of 349,000 public comments received as on 5 of August, as reported this morning, I heard what the Minister said earlier, that the interim regulations were lifted on the 22nd of June and that the 2017 regulations are now in operation. My question on this, however, I hope, will he, as the Minister, bring a final report to this committee before before the publication of these regulations? It's in terms of parliamentary oversight. I think it's just fair for us and for the public who submitted these comments, and also the stakeholders who submitted these comments, to know to get a full report, and I know that the department is still working on these submissions, just to get the indication how many people were in favor of these draft regulations and how many were not in favor of it, just before the publication thereof. On the operation, on the backlog of medical procedures, I've asked this question to the Minister on the 30th of August in a written question, and the reply to me on last week about this. I must say, Honourable Minister and Chairperson, this backlog of 175,000 medical procedures, it's frightening to receive such an answer back when you submitted the question. And this is clearly an indication that the crisis that we currently have and that we are currently being experienced is not going to be resolved quickly. Why I'm saying that, I've asked in the written question to the Honourable Minister what steps have been taken to deal with the backlogs, and the provinces provide the answers thereto. But I also ask what the timeframes will be in this regard to eradicate these backlogs. And I must say, I'm astonishing to see that on the answer I've got back, that most of the provinces said answers were plainly, we cannot predetermine as prioritization is done in terms of urgency. So it looks like to me there is no time frame at all. And I see in this presentation this morning, no time frames could also be given. And this will, if this is going to be the path we're going to walk, I'm afraid that if we don't do something drastically fast, it's going to take us up to 20 years to resolve these backlogs. I think we must look, and it is in an urgent matter. The backlog in the appointment of doctors and nurses must be tackled immediately, and comprehensive plans are needed to urgently catch up with these backlogs in these procedures, as it could mean life or death for patients. And I mean, to wait 2 to 7 years for a hip replacement, I think we as members of parliament, and with respect for Honourable Minister as well, I think we must all, maybe we must go through the pain that patients are going through at this stage, to wait 2 to 7 years for a hip replacement. I mean, it is unacceptable, but patients have to be suffering and endure excruciating pain due to this government total incompetence in sorting out this crisis. We're sitting in a big crisis. Now you want to go ahead with the NHI bill and to put it on table in Parliament for final submission in the National Assembly after we are done with the deliberation. But we are in this crisis. This crisis must first be sorted out. This crisis wasn't caused by the public, who's now suffering and who has to wait 2 to 7 years for a hip replacement. This problem was caused by government by seizing these operations during the COVID pandemic period. And now we have this crisis on hand. The problem is it can't be solved. I'm sorry, Honourable Chairperson, but also doesn't make sense for me, Honourable Minister, is that in the answer you gave back to me, you said Gauteng's backlog were the number of 13,433 medical procedures. But on the 1st of September, it was reported in the media that Chris Hani Baragwanath Hospital alone had a backlog of 11,194 procedures. So the numbers doesn't add up and something doesn't make sense. All the provinces, there's two answers to this. All the provinces don't give you the correct information, or you don't give the correct information to us. So thank you, Honourable Chairperson. That is my person. I hope we can get some answers and clarity on these problems today. Thank you very much.
Thank you, Honourable. The order will be like this now. Honourable Ismail, followed by Honourable Chirwa, Honourable Sheikh Imam, Honourable Munyai, in that order. Thank you.
Thank you, Chair. There's just so much to say. Good morning, everybody, and thank you for the presentations. I also have quite a few clarity-seeking questions and remarks to make. Firstly, on COVID and the vaccines, now we know that SAHPRA has extended the lifespan of some of these vaccines till October. My question is, why is it that the department had not learned from the initial purchase of AstraZeneca vaccines and the date of expiry? A second learning area would be the 1 million doses that had to be destroyed in March this year. My question to the Minister is, why are we having to go through the same expiry issues again. Why were there no contingency plans put in place prior to the expiry date of these vaccines? The reality here is that as a country, we can understand we can make, an error, or we can overlook something at an initial stage. But I can't understand how, the department did not have a strategic plan in place, to ensure that more vaccines will not be destroyed due to expiry. I mean, we've learned it twice already. Now, it's easy to say that, SAFRA has just extended the lifespan, etc., etc. But this is costing taxpayers monies in the billions. And we need to have some accountability tool in place to be able to say that those things don't happen again. Now, what is the department going to do to ensure that the million Pfizer vaccines will not expire after the extension date by SAFRA? And furthermore, the situation also raises questions about the fate of the further 10.1 million stockpile doses of the Johnson & Johnson vaccine that will expire between June and September 2023. Because certainly we don't want to come here next year this time to be able to say that, we've had the expiry now of the Johnson & Johnson because there's been no contingency or strategic plans in place. Really, we've got a problem. Now, what has led to the country's failure of vaccination uptake? Surely anti-vaxxers cannot be blamed solely for this. I've done oversight visits on the ground, hospitals and clinics, and one of my questions always to them are, how are you dealing with COVID? And the response I receive is that we don't even think about COVID anymore. As far as